jaw surgery well executed, well planned? Absolutely. It shouldn't be the boogeyman. The benefits of expanding these airways, giving people ideal skeletal form, there's no question that it is the ultimate treatment that we have to date to fix these issues, get people to better health, better looks, all these things. No question about it. Instead of bending plates in the operating room, we print the plates specific for that patient and for that movement in a 3D printer. And then now what's happening in an operation, I have guides and plates at the bone level that basically guide me to do exactly what I planned on the computer. Millimeters, degrees, in all axes. I can execute exactly what I planned. And then the plate, which is specific and flush for that patient, is going to take me to that final position. And it's also going to act to provide the stability for the patient. I'll look at Reddit too. I'll look at a lot of posts and I'll see people that are under advanced all the time. I'll look at Instagram posts from other surgeons and I'll always say, man, these guys should be more forward, you know? And it's just, that was how they were taught, and it's really a limitation. They're making the right call based on the technology that they're using, and it made sense for them. Now, when I do a case, I'm printing a plate that goes cross-arch, and it's printed titanium. It's not bent. It's stronger. It's going to hold the upper jaw wherever I want to put it. So I have complete comfort bringing it forward a centimeter or more if it needs to come forward. So these are things that may not have been stable, you know, expanding at the time of surgery.
All right, doctor, I'm going to dive right into it, okay?
Let's do it.
Okay, so one of the key ideas on my channel is that a small airway causes bad neck posture, because when your airway is small, you end up cranking your chin forward as a way of opening the airway in spite of the small jaws.
Yeah, absolutely.
That's a condition that I believe led to my occipital neuralgia and 2 migraine nerve decompression surgeries and a period of my life where I was totally handicapped by pain at the back of my neck that was radiating around and causing these debilitating headaches.
Yeah.
Can jaw surgery improve neck posture?
Yeah, actually, absolutely. And I see that all the time. I had 2 patients today post-surgery that was their chief complaint, was neck and shoulder pain, and have seen multiple providers, you know, ENT, dentist, neurologist, and with no relief. And both of them, one was 3 weeks, 3 weeks out of surgery. The other one was 4 weeks out of surgery. Both say that their pain that they've been experiencing their entire life is gone after jaw surgery. And, you know, that was today, but this is something that we see all the time. And we don't only see it subjectively, you know, from patients saying that they report improvement in these symptoms, but we also see it objectively in their C-spine, even on cephalometric films.
So what's going on there? Is it that the airway is opening up and so their neck is allowed to adopt a more biologically normal position?
Yeah, I think what's happening, this is what we think in the community, especially people that are airway oriented, is that obviously the jaws limit the tongue space, right? And you probably hear me talk about this, is that the jaws are the house for the tongue. And in back of the tongue, that oral pharynx, basically your vertebra and your C-spine is a wall that's behind there. So if there's not enough space and that space is limited, people are going to do things with their musculature to open that airway as much as possible. And a lot of that is posturing. And people have these awkward positions and they have difficulty even sleeping on their back because of that airway is so limited. So it's almost out of necessity, because closing that airway space and having limited breathing is not compatible with life. So the body's going to adapt, even if it's going to affect it adversely with pain or abnormal posture or whatever it is, because breathing trumps all of that. If you can't breathe, you can't really live. So it's something that we see, you know, like I said, physically, subjectively, it affects people's lives tremendously, as it sounds like you know very well. And then after surgery, what we do is we bring these jaws forward when it's a skeletal issue and they don't have that room. Now when the tongue has room, it's amazing. Not only the muscles are adapting to this, but the forces on the vertebra and the skeleton completely changes.
Mm-hmm. Mm-hmm. That's amazing. Will you only do jaw surgery on someone who presents with the traditional case like sleep apnea or some type of severe malocclusion, or are you more open-minded when it comes to people wanting jaw surgery for less traditional means like neck pain, headaches, or even aesthetics?
Yeah, absolutely. So I think all of those, almost everybody, and I've been doing this surgery for over 10 years in practice, it's my passion. It's, probably 80 to 90% of my scope of practice is jaw surgery. So obviously I'm going to take on more cases than you would deem traditional, and in that category. And a lot of these patients, like both of the ones that I saw today for follow up, were just very fit, athletic people that wouldn't meet your, what they teach in the schools as a sleep case. And they both had mild sleep readings, although, they had other significant findings where I think they were compensating for those mild sleep readings. But both their chief complaints were neck and shoulder pain, actually.
Wow.
So and then aesthetics is another one that's interesting, because what I think is actually happening, if somebody thinks they're a candidate for jaw surgery, whether they have a concern that's aesthetic or that's, pain related or posture related, when someone comes here for jaw surgery, for whatever reason it is, they almost always have functional issues, that's related to a physical issue with their skeleton. There's a reason that they're unhappy with their cosmetics. There's a reason that they're having these symptoms, and they may not be able to articulate it very well just because they don't know the science or medicine or anatomy as well as someone that is a expert in this field. But so what I do is I'll work these patients up. I'll get a sleep study in the majority of them. We'll take a cone beam CT. I'll do an exam and look at them, and almost all of them have actual physical, anatomical, and functional issues, whether they knew it or not, or they were used to it. They all do. So I think that maybe to answer that question, I may be a little less traditional in my openness to seeking these patients, but once I'm screening them, they all have real reasons why they need the surgery. Almost always. I can't remember anyone, even if, from the outside looks like they may not need it, according to most people. Once we do the workups, almost all of them have real legitimate reasons why they're searching for this operation.
Yeah, form and function are two sides of the same coin. They go together. You can't have an ugly, recessed face or narrow face without also having health issues that go along with that.
Exactly. Yeah,
And
exactly.
do you do that workup because you're trying to get insurance to help pay for the surgery, or are you like a cash only clinic where you don't have to worry about insurance, or you have more liberty to kind of discern for yourself who's a candidate and who's not?
Yeah, I mean, there's multiple reasons for it. I'm out of network for most insurances, but I am in network with Blue Cross Blue Shield, which has a large uh, market here in Houston, actually in the United States. So I see a little both. I mean, I definitely have probably at least half my practice, which is out of network or cash, and then the other half, which is insurance. The hospitals I operate out of, Methodist and St. Luke's, are usually in network with most people's insurances. So
Hmm.
I do have insurance coordinators that will help patients get coverage, whether it's out of network or in network, but definitely for the facilities and anesthesia. But my workups primarily are for medical reasons, to
Hmm.
identify functional issues for the patient and targets for improvement for helping them.
Is it
But they go together. It's
of course.
additive.
Do you find that insurance companies are pretty good about being open-minded to covering jaw surgery, or do you think that there's a problem there in the industry at large where insurance companies are not allowing people to get the surgery they need for a lot of these alternative candidates?
Yeah, I mean, it's an interesting question, and I have a lot of opinions on it just because I've been dealing with it for a long time. I mean, if you think about fundamentally what the insurance's business model is, it's not what our model is. It's not what the doctor is there to take care of a patient, right?
Right.
The insurance is not there to take care of a patient. They're there to service their shareholders and their board members and all that stuff, and it's going to be bottom line. So their entire incentives are going to be to have good profit margins, to get as much profit margins as they can possibly get to meet their shareholders, whatever it is. So the way they operate has nothing to do, and this is something that took me time to realize, has nothing to do with what's best for a patient. Definitely, especially at an individual level, in terms of what they need surgery or they don't need surgery. What they have to do, though, is comply to whatever legal obligations they have in their contract with each individual member. So what it comes down to, and it's very different for everybody's individual plan because they all have different contracts. You and I may have Blue Cross, for example, and you and I will have different contracts. But whatever that contract obligates them to, they're going to satisfy. And if there's a way for them not to cover it, that's what they want, right? So if the doctors don't have enough information that meets the criteria, it's an easy way out for them, for example. Mm-hmm. If the patient has an exclusion of that benefit, and it doesn't matter whether it's a life or death situation for sleep apnea or whatever it is, then it doesn't matter if they need it or not. The insurance is not going to get it. Thankfully, most people, the contracts will cover jaw surgery for functional impairments like difficulty chewing or obstructive sleep apnea that's failed alternative treatments like CPAP or other modalities and appliance, something like that. So I would say that for the patients that we're getting authorization for that have insurance, the majority of them we do get coverage for.
Mm-hmm. Mm-hmm. Yeah, getting coverage for them is almost like a skill that you have, or you probably have a staffer in your office who is really good at that and spends many hours a day just dealing with insurance companies.
That's right. Yeah, we do. But I have Cynthia's been with me for 10 years doing this. She knows it very well. I also know, I know the medicine well, and I know the plans pretty well. So mm-hmm. if it's a benefit for the patient, then most likely we're going to be able to demonstrate that the patient needs it and it'll be covered to some degree.
Right. Jaw surgery is the boogeyman, right? No one wants to even think about it. In fact, the main pitch for a lot of the orthodontic procedures that I discuss on my channel is non-surgical, right?
Yeah.
Do we need to let go of the stigma of jaw surgery being the boogeyman and just confront the fact that we're doing way too much to avoid jaw surgery when really we should be diving into it and accepting all of the great good that it can do for a lot of patients with airway, TMJ, and other issues?
Yeah, I mean, yes and no. Yes, in an ideal situation for a surgeon that knows how to do this operation well.
Yeah. I'm still with you. I'm messing with the windows and going into a solo layout for you just to show off that mural a little bit more.
Oh yeah, do it. Yeah. So I mean, the benefits of jaw surgery, well executed, well planned, absolutely. It shouldn't be the boogeyman. The benefits of expanding these airways, giving people ideal skeletal form, there's no question that it is the ultimate treatment that we have to date to fix these issues, get people to better health, better looks, all these things. No question about it. And it's also the technology now allows us to do it much safer, much more predictable, much more efficient with stability. So the issue is that there's a stigma because traditionally that surgery was not as predictable, not as stable, it was a long operation. So it's understandable that people were reserving it for, very extreme cases. And, when I trained this surgery, I fell in love with it. This was over 10 years ago, 10, 15 years ago. Mm-hmm, mm-hmm. And we didn't have the technology we have now. And I still fell in love with it because of the amazing transformations that patients had. But, back then I was wiring people shut. This is all we knew at the time. We didn't have virtual surgical planning or custom guides and plates. The surgeries were 4 to 8 hours. Now I'm doing it in 1 to under 2 hours, 1 hour, 1 hour and a half. So things are much less invasive, much more predictable, much more stable. So definitely, if it's done well, there's no question that people should be running to this procedure versus trying other things. But for the audience or for people out there, I would really be careful because about where you go, because the truth is that those traditional things that made that stigma what it is still pretty prevalent in our community. So a lot of surgeons that do this operation are still doing it in a traditional way, and it's still a fantastic operation if they know how to do it. It's still excellent, but it still has some, some of the concerns that people had historically with the procedure, but the way
potential to be botched.
Yeah, but potential for risk of relapse or instability or needs for. Yeah, you can put it that way, But the truth is the way we can do it now, and for surgeons that are doing it this way, it is the risk of complications. Sure, it's a surgery. There's always complications. There's always risks. There's things to be managed, but it is extremely safe and predictable and stable, and the recoveries are so much better than historical. You're not wiring the patients shut. A lot of our patients actually can go home right away. They don't have to stay at night. And after 2 weeks, most people are back at work, and the impact of their transformations are phenomenal. They're outstanding. So, it's one of those things that in the next 5 years, I think most surgeons are going to learn how to use the new technologies, and it's a different operation than it used to be. So it shouldn't be the boogeyman.
Can we do a deep dive into that? My audience, just so you know, is very technical, very highly educated on these issues. So we could take it to nerd level 10 or 15 with the details. So how was surgery traditionally done versus how you do it?
Yeah. So traditionally, and this is the way I even train, I'm not that old, is basically we would take tracing paper. We would take a 2-dimensional Ceph, which is a 2-dimensional x-ray, and we would trace out the facial skeleton, and we'd do it twice, and then we'd overlay one over the other and start moving things to simulate where surgery would go. This is real. I'm not making this up. And we would simulate a surgery on tracing paper like arts and crafts. And then based on, that looks like the upper jaw needs to go forward this much, lower jaw to make these things happen. Then we would take stone models and with a face bow transfer, meaning that we'd have a contraption where we can see where the relationship of the jaws were to each other, and take that to what's called an articulator, which is this contraption where you take these plaster models, put it on these fake jaws, and then that's the position where the patient is. And then based on that, we would cut the models and move them to simulate a surgery. This is all on stone at the teeth level. And then when we were happy with that position, we would make acrylic hockey pucks that would register the information of moving one jaw to the other and then moving the other jaw to that jaw. So we'd have 2 hockey pucks. And that was the navigation. That was the information that we got for planning a surgery. Amazingly, we did pretty well with it, and like I said, well enough for me to fall in love with this surgery and find the passion for it and transform these lives. But you can imagine how many levels of error there can be in that, and how much imperfections there are even in the planning and diagnosing from that level of information and technology. And then what happens is you have a hockey puck that registers the bites, and in the operating room, you have to bend plates to make them fit to that. And you also have to measure with a ruler where you're moving things up and down. So again, another multiple levels for error and inaccuracies. And then because the information was really at that tooth level based on that hockey puck, you have to wire the mouth shut. Definitely in the operation to get things fixed. And a lot of times you would do that just because things were so imprecise that we would do that just to keep the bite where we want it. So that's traditional surgery.
Right.
About 12 years ago, mainstream became at least virtually planning. So things got a little better in terms of, instead of the tracing paper, we can go on the computer, take a 3D skeleton and move it on a computer and know kind of where things
What software do you use? Do you use what software do you use?
There's multiple ones. I use Materialize.
Okay. But that software could probably be used for all sorts of physical planning, right? You could probably design, desks or houses or whatever with it, right? It's just a software where you manipulate objects, rotate them, look inside of them, do
Correct.
cross-sectional slices of them, and so on and so forth.
CAD/CAM type technology, right? Yes, exactly. And there's multiple softwares like that offer these things. But that's become the standard, thankfully. And almost everybody is at least using virtual planning and design, which is a huge improvement in the diagnosing and the planning of surgeries, and that made things better. But traditionally, they would then still print out on a 3D printer a hockey puck and do the surgery in a traditional way. So the planning got better, but the execution was the same as that traditional stuff we were talking about in the arts and crafts analog era, right? And that's still how 99% of the world does jaw surgery.
Wow.
They'll plan it virtually, but then they'll take the hockey puck, use the teeth, wire things shut, bend plates, and fixate the thing, and they're still measuring in the operating room. So planning is better, but in terms of execution, there's still a lot of imperfection, instability, and that you're depending in an operating room. And then that's going to make a longer operation, and it's going to translate to potentially more problems. Mm-hmm. Now what we have available and what I use is we plan everything virtually, and then instead of bending plates in the operating room, we print the plates specific for that patient and for that movement in a 3D printer. The 3D printer we use is with Diffuse Synthes, the one I use, and that's in Belgium. But we plan it on a computer, it gets shipped over here. And then now what's happening in an operation, I'm going to execute an operation, and I have guides and plates at the bone level that basically guide me to do exactly what I planned on the computer. Millimeters, degrees, in all axis, I can execute exactly what I planned. And then the plate, which is specific and flush for that patient, I don't have to bend it, I don't have to measure, is going to take me to that exact final position. And it's also going to act to provide the stability for the patient. So that's how the accuracy, the precision, and then the efficiency of the procedure now is possible, where just based on that technology that we discussed, it's obvious to know why it's not possible in traditional methods.
Wow. So it's way more plug and chug now. You design it right, and then there's very little opportunity to screw it up under the knife.
Exactly. So it's measure twice, cut once. Mm-hmm. That's what's happening.
Mm-hmm. It's sort of the Invisalign of jaw surgery.
Yeah, that's a good analogy, because things are done at a computer level and printed out.
And why does this way of doing it result in faster healing?
So in faster healing, there's technologies for that. For one thing, the movements and the execution is going to be better. So what that means is when you do a surgery and there's so much muscle and soft tissue, how should I say it, influence on the skeleton, right? So when you're doing a traditional surgery and you're bending plates and you're weakening those plates, and then you're wiring people, forcing them into a place just to execute, once you take those wires out or the patient wakes up, the muscles, if that position, that execution of the skeleton is forced, and without having a custom workflow, it's impossible not to force that position to some degree, because you don't know where that skeleton should be exactly, right? Mm-hmm. You know where it is, but then when you're putting it, there's no way for you to know that you got there, because you're holding something, holding a plate, securing that plate. Once you take everything off, what that means is there's going to be more tension on the structures. And that's why people use elastics and rubber and wires to kind of force things into place while the bone's healed. But there's a lot of tension in it. When you do the custom way, like, I know in operation that I'm not ready to plate that position until things are passive and flush, because my movement is not where I planned it until I see the holes match up perfectly. So I can't force it to finish it. I know that I'm putting it exactly where it needs to be and passive. So what that does is, in recovery, the execution, the skeleton's in a place where the soft tissue is not pulling on it awkwardly or functioning awkwardly on it. So the bones have a much better chance to heal without disturbing them. So we're seeing those more predictable and better recoveries. And in a way, it's probably a quicker recovery because there's not, unhealthy forces on the bone.
Mm-hmm. Is there any way to screw it up with the new way of doing it?
Well, if you don't know how to use it properly, for sure, there's a learning curve to it. There's a learning curve to know that and to understand it, that you're moving the bone to a place where it should be passive, it should be there. So if people are still used to the analog way and trying to force these things and not being patient, they're going to get themselves into trouble. So it's more of a learning process for the surgeon to understand that this is not analog anymore, and we're not forcing something to get there. It's already built there. And so it's almost a little different kind of thinking and execution to get the surgery done. But for someone that knows how to do it well, it's almost, I've been doing custom for 4 years, and I've never had to throw a plate or change a plan at all. It's always exactly what I planned.
Right. So the key is getting the design phase down. And once you get the design right, then you can count on there being very little margin for error when you're actually doing the procedure.
Yeah, exactly. It becomes way more predictable, way more routine of operation. And that's why it's quicker.
Right. Now, speaking of the design phase, how do you... So I feel like jaw surgery can be screwed up in two ways. It can be screwed up due to user error under the knife, where, you put the screw 1 millimeter off and it results in a cant or something like that.
Right.
It can also be screwed up in the design phase by, for example, under advancing, which is the issue I commonly see. I've had several patients interviewed on my channel who have complained about being under advanced. They get a less than satisfying airway improvement. They're now they look average. Instead of looking bad, they look average, but they were hoping to look good. I have spoken to a few people who claim they were over advanced. How do you strike that balance in the design phase?
Yeah, it's a great question. It's something I talk to surgeons about a lot too when I lecture, is that you're able to plan the cases differently. Not able to. The planning is different once you have this type of technology versus the old. Because, going back to what we described, these traditional methods, because you have plates that you're bending and are weakened, because it's harder to get something exactly where you planned it, and because in traditional ways you're depending on the teeth as your landmarks for positioning the skeleton, all those challenges basically taught the surgeon to compromise on their plans, right? Because if you have all these things where you're afraid things are going to go wrong, if you're fighting tension, if you're not going to be able to make that movement, all those limitations from traditional surgery, then a responsible surgeon is going to say, I'm not going to go for the touchdown, right? I'm going to go for the field goal. And so the planning, even when I learned, was if someone needed a centimeter forward, instead of making that centimeter forward where they optimally should be, we compromised. We split the difference because we knew that this is going to work and the other one is, I don't know. And that's how almost all surgeons are taught to plan, because it's really based on the limitations of the technology. Now I know that wherever I need to take someone, I know that it's going to work. I know it's predictable, stable. My risk of relapse or problems or complications are way lower. So my planning now, it's like a team that has a good quarterback. You can go for the touchdown, you go for the touchdown. So the plan is different. You're not going for the field goal in that situation. And I know it's an analogy, but in a lot of ways, this is actuality in a surgeon's decision-making process. If you have the tools to take you to the right place, you can plan accordingly. So thankfully now, and that's, if you look at my cases in traditional a long time ago versus now, the planning evolves too. Now I know that function is key. And like you said, form follows function. So you give someone the optimal airway, a lot of time that's going to be a bigger movement than surgeons were comfortable making in the past, and why you see. And I'll look at Reddit too. I'll look at a lot of posts, and I'll see people that are under advanced all the time. I'll look at Instagram posts from other surgeons, and I always say, man, these guys should be more forward. you know, and it's just that was how they were taught, and it's really a limitation. You know, they're making the right call based on the technology that they're using. But now when I plan, you're right. I'm gonna look for airway as a key because that's number one. That's number one priority. You got to breathe because if you're not breathing, then like you said, you're going to be in pain from muscle function and all these other things. You're going to age faster physiologically. You're going to get sicker. So priority is airway, and everybody's different. So we use things like the full facial anatomy, their airway, their individual airway needs, their body habitus to know like, okay, this person needs so much of an advancement. And then because we're able to plan and because of experience, then I'm going to take into account facial aesthetics and harmony to kind of fine tune that plan from there.
If your colleagues were to describe your surgical approach, would they describe you as conservative or more liberal or aggressive when it comes to advancing?
My movements, if you go by numbers, compared to traditional and most surgeons, are definitely going to be on the aggressive side.
For yeah, sure. You're going to win a lot of fans with that kind of talk on my channel, Doctor.
Yeah, but if you look at my cases, most of them, you know, they're all coming forward, and I'm going to make appropriate movements. And when I give lectures, that's what I say. I tell them I'm going for the touchdown because I have the quarterback.
So, do you think that most surgeons have the same aesthetic taste, but you guys just have different capabilities based on your techniques?
I think so. Yeah, I think we all have an inherent understanding of what's aesthetic and what's not.
Do you learn about beauty in jaw surgery school?
Yeah, I mean, every program is different. Most programs right now definitely, especially, you know, oral maxillofacial surgery residency and the board of oral maxillofacial surgery has brought cosmetic facial plastic surgery into the arena. So it's a big component of our education and board certification and all those things and things that obviously everyone that's going into surgery has interest in aesthetic results. So both you know, inherently just from people's interests and what the board is doing and the academic programs are doing, I would say most surgeons that are trained in orthognathic surgery are also have a lot of teaching in aesthetics and facial aesthetics.
Right. Yeah, I feel like the top students either go into neurosurgery or jaw surgery, and the neurosurgery is more for like the geeks, and jaw surgery is more for like the students with like high sex drive, but they're also like super brilliant. And like, so you guys have that drive for like beauty and having that sort of, I don't want to say God complex, but you are building faces. So you do have a right to be a little bit, you know, cocky on that front because you are creating faces.
Yeah. I don't know if I'll comment to that degree.
That's my comment.
That's your comment. But what I can say is, and we talk about all the time, you can identify a group of people in an academic center and make a good guess about what they do.
Yeah, let me just put it this way: a neurosurgeon would never have a Kobe mural. They're just not. They're not at that place. You know what I mean?
Yeah, I'll take it.
So, speaking of aesthetics, a lot of people on my channel wonder about the dog face look or the monkey look that happens from over advancing only the lower part of the face.
Yeah.
And just to give people a visual, let me show what that looks like. So I'm going to share now. Do you see my photos album?
Yeah, I do.
So like this case, right? Like this was an aggressive expansion forward, but the mid face didn't come along for the ride, and he ends up looking a little bit like a canine a little bit. I think he looks like he's a fine looking guy here. I'm not ragging on him, but you know what I'm talking about.
I can see what you're pointing at for sure.
Can you comment on how you manage this over expansion, or whether you can kind of make up for it with something done in the midface, cheekbone implants, or Lefort 2 or Lefort 3, or what they call what do they call that? The quadrangle Lefort 1.
Yeah,
Or, yeah,
yeah,
can you
I can
speak on that?
for sure. So it's hard to say without looking at his Ceph and what's happening at the teeth level, because I think that has a lot to do with these positions. Because orthodontics plays a part, and a lot of times, if someone is, a lot of these patients are compensated with their dentition beforehand, and what that means is that obviously their jaws are small and their airway is small. That's why they're going through these procedures where surgeons want to bring them forward, as in that case, right? And for a lot of these people, because there's no room for the tongue, the jaws are small. There's no room for the teeth, so the teeth are crowded, the arches are narrow, right? And a lot of those front teeth are flared out because of that, because they don't have the proper angulation. So I think a lot of these, the planning is key, because if you can widen the jaw appropriately, a lot of these, like that looks like a very narrow face, for example. If you can widen, make room for these teeth, tip those anterior teeth back, then you have more room to bring that face forward without bringing this mouth inappropriately forward. Because if those teeth are flared forward and you're not compensating for that widening and bringing those teeth back, when you make your movement, everything's going to be way out there. So I think a lot of it has to do with the planning. Now, obviously, this may not be the case for him. I can't see his x-ray. And everyone has individual needs. There's a lot of kids with syndromes, craniofacial syndromes and such. I would say for a non-syndromic patient, because syndromic patients, craniosynostosis, those things, they're going to need maybe a Lefort 2 or 3 higher cuts and bring everything forward with it. These are rare, For most people that have these deficiencies, if they're compensated well and there's a good orthodontic plan, I think that solves a lot of it. I think in terms of planning too, in 3D planning, the orientation, the pitch, putting a appropriate angulation to the jaw makes a big difference. And then the type of Lefort cuts, you have a 2 and 3. I think the 2 and 3 are good for true craniosynostosis, craniofacial deformities. But otherwise, a high Lefort cut where you come higher and you can modify these things. So it's doesn't have to go to the orbit through the orbital rim exactly, but can go close to it and make a step. You can get a really good aesthetic result without having that imbalance, because at the end of the day, it's all about harmony. And if you're bringing things way far forward, more than the cheekbones or zygoma, it may look inappropriate. But if you can alter the zygomatic bone with it, most of the time you don't have to go to the orbits or above to do.
So you would be open to performing a Lefort 2, or you think a Lefort 2 could sometimes? Yeah, go ahead.
I think there's definitely candidates that need a Lefort 2, but I would reserve those. It's a riskier operation, and I think that I would reserve those for people with true craniofacial abnormalities. If someone has a Treacher Collins, for example, or these autosomal dominant things where they're really hypoplastic, they're rare. I see a lot of people asking for Lefort 2s and 3s, and I think that for most of these people where I'm reading these requests, a high Lefort, appropriate decompensation, and getting that cheekbone out is going to give a really, really good result and much safer.
Yeah, the people asking you for Lefort 2s and Lefort 3s, where do they come from? From Reddit?
DMs on Instagram.
Yeah.
A lot of times I see it on Reddit a lot too, and I look through these things. And there's definitely candidates that require. I think they're good candidates for 2s and 3s, but I think most of the people are asking need better planning and execution with safer custom planning.
Would you do a 2 or a 3 ever?
I would work with a craniofacial surgeon in the med center to do one. But personally, I reserve that for when I'm at Texas Children's Hospital doing collaborative care versus not.
So you don't think that Lefort 1 is an inherently asymmetric procedure, in that it's only looking at underdeveloped faces too low down, where it should look at underdeveloped faces more three-dimensionally. You don't agree with that?
Yeah, no, I know that through experience and with custom planning and designing the cuts appropriately, staying under, not having to go into the orbit itself, you're going to get 95% of people and make a very aesthetic face.
Mm-hmm. Mm-hmm.
But if it's cut low and you're not going high on the zygomatic arch, you're not making appropriate movements, and you're not decompensating the teeth or widening the arches appropriately, then it's not going to look appropriate. Then you're right. Then it's narrowing your scope.
Do you ever tack cheek implants into a procedure?
I've done them in the past when I was doing traditional non-custom cases, but now when we can go high in a Lefort, we can make the cheeks as enhanced as they need to be, without having to put a foreign implant in there.
I heard someone say that genioplasty is only necessary in cases that are under advanced. Do you agree with that?
No.
Do you often perform
Yeah.
genioplasties?
Yeah, I'd say probably at least 50% of my cases get genioplasties. And what happens is it just depends on the facial requirements. It's very specific to someone's skeleton.
Mm-hmm.
So some people have no real chin form. They can have microgenia independent of mandibular hyperplasia or hypoplasia, right? It's just the anatomy of the chin. Their chin can be asymmetric compared to the rest of their jaw. So usually what I'll do when I'm planning a case, I'm going to put their upper jaw, lower jaw in an appropriate position and orientation. And then if that chin point is off to one side, if it's canted, if it's too flat, if it's too long, if it's too strong, those are all independent factors for the patient that I'll decide to do a genio to make it appropriate.
Yeah. You know what I think happens, doctor, in the in the lay community that becomes interested in jaw surgery? There's this sort of sexy idea that everything happens in harmony, so that if you're underdeveloped equally everywhere. And there's
Exactly.
not a lot of consideration given to the fact that nature is not always so elegant. Sometimes a person's upper jaw might be less underdeveloped than their chin, and their chin
Right.
might need a little extra oomph. Is that kind of what you're saying?
Yeah, I love that actually. And I think that's very true. It's exactly what I'm saying. And I think that people want, dogmatic recipes and solutions. And they think of things very binary, like a genio is going to bring you forward. But a genio can move in all ways. And I'll use them in all ways. And you're absolutely right. There are a lot of patients that have underdevelopment or overdevelopment, one jaw, both jaws in asymmetry, have plagiocephaly. They may have dystopia where one eye is higher than the other eye. But
Right.
You're right. Things depending on why something went wrong in the development for that patient, whether it was trauma, whether it was a kick to the face or an elbow playing basketball when the kid was 5, or it was a genetic component, it was allergies, whatever that reason was that caused that deformity or to happen, is not going to be the same for every person.
Right.
It's not going to be symmetric. It's not going to be one part in relation to the other part. So you're absolutely right. All the patients have very different needs.
Speaking of different factors that can cause facial underdevelopment and facial issues, in your Kobe mural, I'm seeing mouth breathing in one of the images, and I'm seeing oral fixation, chewing on the jersey in another one. What's going on there, Doc?
I love it. Totally purposeful.
Are you sure? You should have brought a myofunctional therapist in to consult on
Absolutely.
that mural.
I
No.
wish he was around so I can work with him on it.
Oh man, no. The Mamba's good, man. He's good.
Yeah, I'm with you.
Now,
That means a lot from a guy from Boston.
for sure. No, hey, if you don't have respect for the Mamba, there's something wrong with you.
Yeah, I'm with
It's
you.
like not liking the Beatles. If you don't like the Beatles, you've got issues, not the Beatles, right?
You're right.
So, the mandible. How do you feel about mandibular midline distraction and torquing the the mandible outward and the potential dangers that poses to the temporomandibular joint. In general, what's your approach to mandibular widening?
Yeah. So with widening, a lot of it we're going to try to do orthodontically and with genioplasty. Also, for a lot of these uh, hypoplastic mandibles,
What
as
do
the
you mean
jaw
by hypoplastic mandible? Can you define that a little
small,
bit?
yeah,
Oh,
hypoplastic just means underdeveloped. So you're right. It could mean retrognathic, so behind. It could be short, whatever it is. But a lot of these jaws that need enhancement, which is a lot of these patients, bringing those jaws forward, elongating them, is gonna give a V-shaped appearance to those mandibles and make the jaws look wider. Torquing the condyles is dangerous. It's a dangerous thing to do, and it puts the TMJs at great risk and causes a lot of morbidity. So
hmm. Hmm.
I would try to avoid widening here and flaring out the condyles. And actually, when we do custom surgery, I'm able to control that proximal segment. The proximal segment is the part that's attached to the condyle. So when we split that mandible, bring it forward. The nice thing about planning it and making a custom plate is that I know when I plan it and I keep that condyle neutral and make that plate adapted, I know for sure that I'm not going to swing that condyle out of position. And there's no way to know that with traditional surgery. So I'm glad you brought that up. So what happens is a lot of, and I'll still look at this and this questions come up, is that TMJ is a big risk after jaw surgery, right? And
Right.
TMJs get worse and all those things. And it's true if that condyle is torqued out of position. And with traditional, there's no way to know when you put a plate what's happening to that proximal segment. It's impossible. With a custom plate, you know that if it's flush, you haven't moved anything. So that's a great point. Now, in terms of widening, orthodontic, widening as much as possible, we try to take advantage of. I expand the maxilla a lot, with
Orthodontically?
no, surgically.
Okay.
Surgically, because that's a very safe thing to expand, and we usually will try to widen the lower jaw arch orthodontically. And most of the time, the narrowing, because of the way these things are developed, is more so in the maxilla than the mandible. So most of the time, the lower teeth are tipped in and narrow to match the narrow upper arch. So when we widen the upper arch orthodontically, we can widen the lower arch without having to do anything with the condyles, but still get a better widening of the jaws.
Right.
So yeah, that's the answer on that.
So I think a lot of people struggle with this idea that by advancing the mandible, you're widening it. And the way I tell me if you agree with my way of demonstrating it. I often say to people, okay, look at my chin when I do this, right? You're not
Yeah,
seeing my jaw. But then when
correct.
I go like this,
Yeah,
now all of a sudden I have a big jaw.
yeah,
So so there's a lot of jaw that's hiding in the
for sure.
neck when
Yeah,
it's
for sure.
recessed, and you're basically just bringing the wider part of the jaw into visibility.
Yeah, that's a great way of putting it, and it's demonstrated. If you look at most of the before and afters, look at all of them. Their angles look wider
Mm-hmm.
after that advancement.
Mm-hmm.
Now, the other thing about widening arches, something called SFOT. I don't know if you've heard of that, but
Yeah, yeah, I
surgically
have.
assisted orthodontic therapy. And what we can do is, if orthodontically, if there's not enough bone to tip those teeth out and get them where we want, we can do SFOT, where we make corticotomies in the bone, put bone graft and membrane, and build bone outside so that the teeth can actually be moved orthodontically to widen some spaces. So for a
Mm-hmm.
lower jaw that truly needs widening, and it's not just a matter of tipping, a lot of times that's also a great option to set the person up for wider arches.
Mm-hmm. Yeah, we're quite familiar with SFOT on my channel, although my audience generally has a preference for Dr. Yusefian's approach of
Yeah,
skeletal midline expansion.
yeah,
Um, but he's literally the only guy in the country
yeah,
who does it, and
yeah,
that's very frustrating to people. But the more I ask around, the more I'm learning it's because people are very cautious about, risks to the temporomandibular joints.
Yeah, it's a serious concern for sure. Now, distracting, if I were to advocate for anything, distraction is probably a safer way to do it.
Because you can take it turn by turn. If you're having pain, you turn back. You're going a fraction of a millimeter at a time.
Yeah, and you may give the body has an amazing ability to remodel and adapt. So if you can do it slowly over time, there's a much better chance that's going to be healthy.
Speaking of distraction, in terms of maxillary distractors, when it comes to transverse expansion of the maxilla, are you usually doing that as part of your surgical planning, or do you like to have an orthodontist take care of that with like a MARPE before surgery?
Yeah, I do it both ways. I work with some orthodontists like Mariana Evans, who's very familiar with the MARPE and is very good with it. And so for those narrow maxillas where the orthodontist wants to expand first and then set me up for a non-segmental maxilla, I like that as an option. But otherwise, I would say the majority of patients that need expansion, I'm usually going to do that in a one stage, and I'll do a segmental Lefort and double jaw at the same time. And because with the custom technology and piezo saws, an ultrasonic saw, we can do the expansion just as safely as we can do a distraction. And that, I think, for the patient, one surgery, one recovery, versus that distraction, which is not always necessary, I prefer.
I did hear Dr. Gunson say recently that it's ideal to do the transverse expansion orthodontically because when you're doing it surgically, you're limited by the width of the mandible, and you can only widen the maxilla as much as the mandible allows. Whereas when you do it orthodontically, you can expand the mandibular teeth with the MARPE device and get a more robust transverse expansion. Do you have any thoughts on that?
Yeah. So also individual, and so what the orthodontist can do, if the orthodontist knows, for example, and a lot of orthodontists know that I'm going to plan for a segmental upper jaw, they're still going to prepare the lower arch accordingly so that I can expand it to an expanded lower jaw. So
right.
In terms of timing, it's just a dance between the orthodontist and the surgeon. But it doesn't have to be fixed into that solution because you can prepare an upper jaw for a segmental expansion while you're preparing that lower jaw for that expanded arena to that same point.
Right. So you would do maybe you do an SFOT and you end up with lower teeth you end up with a crossbite before surgery with the lower teeth being wider, and then you correct that surgically.
Right. Exactly.
While still on the subject of distractors, do you have any thoughts on the IMDO procedure that Dr. Kociancic does, the mandibular distractor that brings it forward?
So it's a mandibular distractor?
Yeah.
Distraction osteogenesis of the mandible. I'm not familiar with his, but I'm not a fan of distraction for the mandible at all in this day and age with custom technology.
Just to give a visual, I'll put it up on screen what that looks like. I'm also just learning about it, but my audience is pretty crazy about it. Everyone wants this. That's kind of what it looks like right there.
So between the first and second molar?
Yes. Yep. I think the IMDO stands for intermolar distraction.
Yeah.
And apparently there's also a widening that occurs with this as well of the mandible.
Yeah, that's interesting. And then is he avoiding a double jaw surgery?
I think he's doing a lot of IMDO without any Lefort cutting. Yeah.
Yeah. So I don't like that because it's compromising the plan. Because almost all patients, I believe, will benefit from a double jaw. Very rarely, very, very rarely is someone have one jaw that's perfectly normal in shape and form, and then the other jaw abnormal. So what happens in single jaw procedures, these are field goals. These are compromised results because you're just taking one and you're limited by the other. So and I try to make this point a lot, is that with custom technology, I can move someone. I've moved someone 35 millimeters at a pagonion in one movement with a custom plate and good regenerative bone product, and it healed perfectly well. And I do big movements like that all the time. And we're going to do double jaw and get everyone exactly where they need to be without compromising. So I don't favor distraction for that reason, because prior to the custom titanium plates and planning, yes, we didn't have confidence taking people to certain places and making big movements. So we relied on distraction, and that I trained with distractors. But nowadays, I know I can elongate a jaw even more than that distractor can maybe elongate the jaw and get them there instantaneously in the right place in all 3D forms and not limited by two-dimensional or another jaw.
Right. Yeah, I like your comment about field goals. And with all due respect to Dr. Kociancic, because I'm sure he's great, and he and I have tried to connect and
Yeah.
to get him on the channel. But I think there's a lot of field goal kicking that's done to avoid Lefort cuts.
Yeah.
And the analogy that I often use with patients is it's the things that people do to avoid full-on jaw surgery. It's like people are buying Toyota Camrys, and then they're putting on the new exhaust, and then they're getting bigger brakes, and then
Right.
they're putting in a supercharger, and it's like, just buy the Lexus.
Yeah.
Stop fiddling with the thing to avoid what you should have done in the first place, which is just buy the car you wanted.
Yeah, absolutely. That's a great analogy. And I think a lot of it is, there's certainly a market for people that need bigger airways, better aesthetics. There's no doubt about that. And there's limited resources in terms of people that are able to execute jaw surgery at the appropriate levels. So what happens is that market makes a lot of people promote and provide what they're limited to. So there's a ton of appliances on the market that are not ideal, that are going to just move teeth out of bone or move one arch a minimal distance, or, a lot of ENTs will do a septoplasty turbinectomy just because there's no room. They'll take away the furniture because the house is small, right?
Right.
But really, you got to make that house bigger. So unfortunately, there's not enough big-time construction businesses that can build the bigger houses. So you're seeing a lot of people taking out furniture, if that's an analogy for you. And I think you're right. There's a lot of field goals being kicked for that reason.
Yeah, no, I'm with you. I talk constantly about making the room bigger instead of taking out the furniture. And soft tissue nasal surgeries are advocated on my channel only as a last resort.
Yeah.
It's the icing on the cake. It's the sauce, not the meat. You got to do the bone expansion first.
Right.
While we're on that subject, does having prior nasal surgery present a challenge to doing jaw surgery?
Not at all. I mean, unfortunately for most patients, I would say half of my patients have gone through so many other modalities before they get to me, and a lot of those have had nasal surgeries. Thankfully, they never really present limitations or complications in terms of my ability to get them where they need to be. The only thing is that it'd be nice if they never did it in the first place, because most of them could have avoided it.
Yeah, right.
But it doesn't preclude them from doing it.
There's the dreaded empty nose syndrome that comes with messing around with those tissues in the nose.
Yeah, that's
They're
problem.
not meant to be cut up and hit with lasers.
No, I agree 100%. And
they're super delicate.
Very rarely does someone truly have a diagnosis of turbinates that are too large. Almost always, it's a skeleton that's too small.
And if they are too large, maybe improving the airway gives them a chance to heal and get smaller.
Correct. Yeah. Correct.
I tell people that it's way better to do big traumatic things in the mouth than in the nose, because the mouth is meant for getting beat up. You chew things with it, right? You put all sorts of things in your mouth and it can handle it, but the nose is like, it's delicate.
Yeah, and those turbinates, that respiratory mucosa is really important.
Right.
A really important gateway for pathogens and toxins in the environment. So, I would agree not to disturb that for sure.
What other, could you name 2 or 3 other surgeons in the country that you respect or that you look up to? A big thing that happens on my channel is that top doctors are sort of idolized and made into celebrities. They're classified as like A-list, B-list, C-list. Who are your A-list jaw surgeons?
Yeah. So without any bias, but this is true respect, my colleagues, Dr. Hassan and Dr. Carrillo.
Yeah.
But for good reasons. They're excellent surgeons. They both did a fellowship here with me. They learned everything had to teach, and they're excellent guys. They can do these operations well. So definitely look at them. Dr. Ed Buchanan at Texas Children's, uh, excellent craniofacial surgeon, and treats a lot of children with big deformities. And then I see work from Alfaro and Raffini, and I respect them. I respect both their work a lot.
Do they use the same methods that you use?
No, they use virtual planning, and they have a lot of good. They have a lot of experience, and they have a lot of understanding, I think, of function and airway, but they don't have the privilege of the 3D custom plates and guides in these countries. And it's something I'm integrated well in the process of this technology, and I know good surgeons in Europe, and in South America, but unfortunately, they just don't have the resources like we have them to use this technology yet. So,
yeah, but if you had to pick a surgeon who was just doing it by hand and eyeballing it, Raffaini would be up there, right? He's amazing,
sure.
right?
Yeah, he would be up there for sure, and Alfaro would be up there also.
Do you think that there's something about Italian surgeons where they have some heightened sense of beauty because like they're in that Italian culture where beauty and like the finer things are really valued? Or am I just making that up?
I can buy it. I mean, they're for whatever it is, whatever they're designing is beautiful, right?
Yeah.
I wear Italian shoes often, and but yeah, Italian designed things are good. So there could be something to that for sure.
Yeah, I think so. When you look at me, and I'm not looking for a free consultation, but when you look at me, do I jump out at you as, yeah, he could handle a surgery, or would you say, no, he'd be crazy to consider jaw surgery?
I'd have to get a close-up evaluation of you. From what I can see, your mandible projection and shape looks very nice and aesthetic.
Mm-hmm.
What I can't tell is your upper jaw. From looking at you here, it looks like it may be short. I don't see a lot of tooth show in there, so yeah, you have a nice arch form. You have a nice bite. The only thing that I may want to look at is your vertical dimension in the upper jaw. Could use maybe a little more projection, but otherwise, you're not an obvious candidate.
Yeah. So do you mean like my maxilla might be a little bit downswung and it could use a little bit of love in that direction?
Yeah, or actually even more tooth show. I think it could be too short.
So what would the surgical movement be on me, for example?
Let me see
And
your profile.
I only ask because
Yeah.
my channel was built around my case. That's how it all started. And
Okay.
people asking me
I don't
all
know
the
anything
time.
about your case. Yeah.
Yeah. So you want to just see like my side profile?
Yeah. Yeah. So profile's pretty good. It's hard to tell what the angulation of your lower jaw is without an X-ray. Maybe upper jaw and lower jaw a little deficient in the projection.
Yeah. Yeah, I feel that. And I have had a MARPE, which made my maxilla wider.
Right. Yeah, and that looks nice. Your arch form looks good.
It's big. It's a little canted.
Yeah. So a cant surgery can correct, and if anything, you'd probably come forward and down.
Yeah. Yeah, and I feel my airway definitely collapses when I sleep face up, so I have to be very careful about my sleep posture in order to keep it open in my sleep.
Yeah.
I did see a surgeon in Boston, Dr. Pushkar Mehra. He's at Boston University.
Yeah.
He's the local airway guy.
Yeah.
And he was very lukewarm about operating on me, wanted to see proof of sleep disordered breathing.
Yeah.
Suggested to his the resident that was with him. He didn't really talk to me. He was a little bit distant. He spoke more to his resident than he did to me. Obviously, he didn't know who I was, but he was very lukewarm. And I think he's probably more traditional, where he's very conservative and
And most of the academic centers are going to be more conservative.
Yeah,
for sure. But yeah, you want to come to Houston to see the Kobe mural in person, and I'd be happy to evaluate you.
Yeah, awesome, man. Thank you. No, if I do surgery, it'll be with you for
I
sure.
appreciate that.
Oh,
I
no doubt,
appreciate
man. Hell yeah. Um, Technical question.
Yeah.
What's the difference between down-grafting and impaction? And when is either of those necessary? What do you generally do? A patient came on my channel and said that
Mhm.
he got impacted when he should have been down-grafted, and it led to a very poor result. It was all sort of Greek to me. Can you explain all that?
Yeah, for sure. So impaction usually is reserved. It means pushing the upper jaw up, pushing the maxilla up, and that means trimming bone and plating it in a higher position. Down
Right.
grafting means taking that maxilla and pushing it down, and usually that means you're going to have a gap right in the operation, and the plates are going to stabilize you, and you're going to bone graft that gap and let it heal, and then it's going to heal in that elongated form.
Right.
So usually it should be pretty clear cut who needs an impaction, who needs a down grafting. If someone has a short face, they don't show their teeth. You can't see their upper teeth past their lips, and it looks like their upper jaw is hidden. Those people are going to need to be down grafted. If someone is showing their entire central incisor and a huge gummy smile, those patients are going to need to be impacted. Now, what happens is with the traditional, and I think this is probably where this question is coming from, in a traditional surgery, one of the most unstable movements was down grafting an upper jaw. Because what happens is there's a gap between the upper jaw and lower jaw. So if you have plates, these 4 little plates that people use in traditional surgery that are bent and they're not that strong, and then you're trying to move an upper jaw down and forward, and the only thing holding it in that position are these little plates, it's unstable. Most likely what's going to happen is it's going to get loose, and those screws are going to get loose, and over time you're not going to have a good bone union, and you have a non-union. So in traditional, and this is the way I was even taught, and I think people still read the North Carolina paper from the 80s about hierarchy of stability in orthognathic surgery. I think they still teach these things, is really based on that old technology. And it made sense for then. Now, when I do a case, I'm printing a plate that goes cross arch, and it's printed titanium. It's not bent, it's stronger. It's going to hold the upper jaw wherever I want to put it. So I have complete comfort bringing it down if it needs to be brought down, and then putting bone graft in it will heal. Bringing it forward a centimeter or more if it needs to come forward. So these are things that may not have been stable. Expanding at the time of surgery on a 3-piece, transverse expansion traditionally in those North Carolina papers, also not a stable movement, classically. But those are all based on old technologies. But now we can down graft. It's just that if they're not using a titanium printed custom plate and they're not fully understanding what type of procedure we can do now in this day and age, they're going to subscribe to that old classic teaching, which unfortunately is still 99% of the surgeons out there. And this is what we talked about planning. Their plan is going to be different. That's a field goal because that's more stable. That's more stable to put it up and not have a gap. But what you're doing is you're shortening that upper jaw when it needs to be lengthened.
Wow. Yeah, I think that this really is an issue, that there's so many surgeons out there that are just doing things with one hand tied behind their back, not using the modalities that you're using to get more predictability and therefore more comfort in doing the movements that need to be done.
Yeah. I think that's absolutely true, actually. And it's not to their values are right. These are good people. I know them. They're good surgeons. They're smart. They were top of their class, and they're good people, and they mean well. But they're just limited by what they've been trained to do and what they're comfortable expanding their knowledge in. Hopefully, what'll happen is as we train more people to do it this way, we're going to see less of these field goals in the future.
How did you get into all this stuff? Are you one of those guys that like had an engineering major or like an architecture major or like a design major before you became a surgeon? So you had some sort of cross-disciplinary influence that led you to this way of doing it?
Yeah, it's a great question. A lot of being in the right place, right time, having the right interest. I was I look back at the way I like to learn. I was never someone that can read a recipe and cook a meal, or sit in a classroom and just hear what the instructor is teaching. Or even in IKEA, for example, my brain doesn't work that way. I can't pull the pamphlet out and build the thing. I have to just look at it and understand it and kind of make it work for myself in a way that my brain understands. So I think part of that is kind of just the way I'm wired, is that I need to understand things the way I need to understand them in a macro big picture. I'm more of a big picture kind of guy, and go from there. So I think that's a component of it, and not just doing as I've been instructed, even when it doesn't make sense, for example.
Yeah.
And I've always kind of studied that way. In dental and medical school, I kind of just had to go into the library and research things my own, and kind of figure things out in a way that made sense to me. And when things didn't make sense to me, I didn't like learning them that way. I just had to kind of figure them out. So I think part of that is in that territory. It's like, the surgery is awesome, but why? I know there's technologies out there that we can use to do it better. So part of that, while I was doing this surgery for the last 10 years, is like, how can I get it better? What's available out there? And then being graduating at Columbia when I was a fifth-year resident, I started a research project to build stem cell mandibles in pigs. So a large animal study where we engineered ramus with stem cells from fat, and we were able to build these jaws in a bioreactor, and it worked, and it was awesome. And I kind of fell in love with that investigatory process, and really befriended the engineers at Columbia University, and really kind of got interested in that study. And I think when I came to my career, I really found that passion for that 3D technology, CAD CAM software engineering. So engineering in a way, not in a formal teaching, but almost through this indirect informal teaching, I did become interested in it, and kind of dove into it. And I think those two, wired brain and learning process with the engineers, put me on this path to get jaw surgery where we have it now.
Wow, man, that's amazing. Have you ever done a Myers-Briggs personality test by any chance?
I don't think I did.
I'll bet you if you did, you would end up being an INTP.
Tell me
Has
about
anyone
that.
ever told you were an INTP?
No, what does that mean?
So INTPs are very resistant to authority. They like to do things their own way.
Okay.
They must understand the big picture.
Yes.
They like to connect lots of different ideas to create a unified theory of everything.
That's amazing.
Their work cannot be totally hidden from the world. They're most inspired to do work that other people can see. That's what motivates them, letting other people having their work be on
Yeah.
display in some public way, even though generally they're somewhat introverted.
That's
Like,
amazing. That totally describes me.
yeah, that's cool, man. A lot of my favorite sort of thinkers and scientists are INTPs.
That's amazing. I'm gonna do that study. But
Yeah, hell yeah.
I think that, I definitely identify with that description you just made.
Yeah, for sure, man, for sure. I'll let you go in just a sec. It wouldn't be a jaw surgery interview without a very brief discussion of recovery, because that's the boogeyman that keeps everyone
Right.
away from doing it. How
Yeah.
bad really is it?
So much better than it used to be. And we're
Hmm.
talking about this traditional versus custom and where we are now. So if you
Yeah,
think
yeah.
about that surgery, traditionally it's an 8-hour operation. People are wired shut. Their mouths and soft tissues are stretched for 8 hours, and it's the stretching that causes so much of an inflammatory process. And 8 hours of stretching is very traumatic to the tissues. And then you wire the mouth shut. There's no question that was a rough recovery, and still is for a lot of patients. Now, if we can take that down to a 1-hour operation or 1.5-hour operation, which is the way I can do it now, and limit the amount of stretching and trauma to the patient, and then also not have to wire them shut, get them into a position that's more passive, not fighting, I don't have to make it up for you to understand that it's going to be a better recovery, right? And I've seen that happen. So most of my patients stay one night and are ready to go the next morning.
Wow.
And recently, if my morning cases, I'll even send them home the same day, and they'll do great. The patient I had today, she said she had 0 pain in her recovery, or 0 to 2 pain in her recovery. And, that's not the norm. Most people will have some pain. But I would say the majority of the patients that I'm treating will take Tylenol and ibuprofen with some type of narcotic for breakthrough in the first week. After 1 week, most of them are off the narcotic and are taking Tylenol and ibuprofen as needed. And after 2 weeks, the majority of my patients are off pain medicine and very comfortable and back at work.
Back at work, so they're not looking like zombies 2 weeks later?
No, they're 2 weeks. Most of them, almost all of them, are back at work. Now, there are exceptions, and everybody's a little different. But I would say a good 80 to 90% of them after 2 weeks are ready to be at work.
Yeah. Generally, I find with surgery, the healthier you are and the better your lifestyle, the faster you heal. Obviously, there's going to be some people that abuse themselves, that are whatever, overweight, diabetic, so on and so forth.
Correct.
They're gonna be swollen longer, but
Yeah.
if you're healthy, you'll probably heal pretty quick.
It's very true. And then the other thing, which is something that I've witnessed and completely believe because I've seen this happen, positivity makes a huge, huge difference in recovery. Patients that have an optimistic belief about how they're going to do after surgery and a positive tendency do physiologically better than people that don't. And it's really amazing, but the cells listen when you speak. And as an MD, it may be crazy for someone to hear that, but this is proven true, and I see it all the time.
No, that's amazing. I totally buy that. I think that pain in the body, there's so much about them that's mental, and that makes things complicated. But you can definitely use that to your advantage and
Absolutely.
work that in your favor. I'm a
Yep.
big proponent of fasting after surgery, at least for 3 days or so, to just give your body an opportunity to do nothing but heal.
Yep.
That's what I've done with the surgeries I've had, and I've gotten great benefit from it. So I think if people are scared of doing surgery because of the recovery, there's a lot that you have control over with that.
Absolutely.
That's
for sure.
The message I want to put out there.
Yeah, I agree with you 100%. And I think, if you talk to my patients that have gone through this, most of them will tell you it is not at all as bad as they expected. And they'd all tell you they do it again.
Mm-hmm. Hell yeah. All right, Dr. Alfi, thank you so much for your time. That was an awesome hour.
Yeah, appreciate it.
Tons of golden nuggets of information, and I hope we get a chance to speak again sometime in the future.
Absolutely. Happy to host you here in Houston. Just let me know.
Thank you, doctor. That means a lot. Appreciate it.
All right. Take care.
Bye-bye.
Thanks for doing it.